have been talking about the retina OCT, interpretation of fluid in the retina OCT, particularly at the macula. So let's start with the basics first. This is anatomy of the cone cell, as you can see here. So it has an outer segment and an inner segment, as you can see here. And the outer segment and the inner segment has two portions, the ellipsoid as well as the mynoid zone. This is the nucleus of the cell and this is the axons. Now apply the same thing to the OCT here. So this outermost hyperreflective or white layer is called as the RPE, and after that comes the COS for the cone outer segment tips. That comes the cone outer segment tips. Am I audible clearly?
Yes, Dr.
Am I audible clearly?
Yes, you're audible. Please go ahead.
Okay, so this is the cone outer segment tips, which corresponds to this portion. Then you have one more white line, which is the ellipsoid portion of the inner segment, which is this. Okay, and then we have the external limiting membrane. So this is the outer retina. The importance of this area is if there's any pathology here, it significantly affects the visual outcome. Okay, then coming to the inner retina, so we have the hyperreflective and hyporeflective layers. So all the hyporeflective layers are nuclear layers, whereas all the hyperreflective or the white layers are plexiform layers. So we have outer nuclear layer, outer plexiform layer, inner nuclear layer, inner plexiform layer. Then we have the ganglion cell layer and the nerve fiber layer. Okay, so the nerve fiber layer is always thicker on the nasal side. So when you're seeing a printout, if the thicker NFL falls on your right side, it is the OCT scan of the right eye. If it falls on your left side as you visualize the printout, then it is the left eye. So this is a simple trick to identify if it's the right or the left. So why it is important to know what is the inner and the outer retina? Because there are certain pathology that begin in the inner retina and certain pathology that are typically localized or begin in the outer retina. So I have listed them here for your reference. So what is the pathophysiology of fluid in the retina? So anything that causes increased blood pressure can cause increased leakage and increased retinal thickness. Sometimes there's tissue cyst formation, which reduces the retinal tissue pressure. So there's increased leakage from the surrounding vessels. Sometimes traction from the vitreous can cause increased fluid entry into the surrounding tissues. Also, when an RPE pump does not pump out the fluid, there can be accumulation of subretinal fluid. So fluid in the retina can be at two levels. One is subretinal and intraretinal. When I say subretinal, I mean it is between the RPE and the rest of the layers of the retina, like you see in exudative RD and rhegmatogenous RD. When I say intraretinal fluid, I mean it is within the layers of the retina in the form of cysts. So coming to diabetic macular edema, we have mainly intraretinal fluid here in the form of large cysts. So in this case, as you can see here, it responds very well to the anti-VEGF or steroid injection. In some cases, it does not respond at all and it remains as chronic cystoid spaces. This is mainly because of inflammation and vascular leakage. In certain other cases, there is traction by the vitreous. So in such cases also, the fluid does not respond to anti-VEGF. We have to do a vitrectomy to relieve this traction so that the edema reduces. Okay, so this is also an epiretinal membrane which causes traction on the cystoid spaces here. So as a result of which, even if you give an anti-VEGF, it is not going to respond. The culprit is the ERM, it has to be removed surgically. So coming to vein occlusions, here we have the typical cystoid macular edema where you have both intraretinal fluid as well as subretinal fluid. So intraretinal fluid is in the form of this well demarcated cysts with septa, and subretinal fluid below it is seen here. So these sort of edemas respond very well to steroids and anti-VEGF. You will also see them in pseudophakic cystoid macular edema post-cataract surgery, or which is also called as Irwin gas. Okay, Irwin gas is sometimes missed on an 90-day examination, so you may need to do an OCT if you don't see visual improvement after cataract surgery. So this is another patient where you think it is a vein occlusion, but when you do the OCT at the macula, you find this inner white hyperreflectivity of the inner retina. So this means it's an ischemic inner retina with retinal edema. So this is seen in CRAO or combined occlusion, that is artery plus vein occlusion. So you can pick up a combined occlusion on this OCT scan because of this inner hyperreflectivity. In central serous retinopathy, there is no vascular leakage from the retinal vessels. Hence, you do not find intraretinal fluid. You will find only subretinal fluid. Sometimes you may find a pigment epithelial detachment. Okay, and it is because of RPE dysfunction as well as leak from the choroidal vessels. In patients with, if you're planning for a multifocal IOL and other high-end premium IOLs, it's better always to do an OCT preoperatively. You may, because you will miss out foveal thinning. So if you see foveal thinning, you can counsel the patient for other normal IOLs, or you can give them guarded visual prognosis. In case there's a posterior subcapsular cataract, so we'll get a scan like this, a raster scan. So in such cases, it's better to do a line scan of a single cross section so that you get a better area, better resolution to identify if there's any pathology. Sometimes what you can do is, if your cataract is blocking your OCT acquisition, you can get around the cataract and take a better image. This depends on the skill of the person or the technician who is doing it. So you can just focus it a little around and you can get a very good quality image to know if the retina is okay prior to cataract surgery. So in coming to age-related macular degeneration, you find this lumpy, bumpy RPE. Sometimes you see yellowish lesions on fundus examination. You're not sure if it's a hard exudate or if it's a drusen. If it's a hard exudate, it will normally be present at this level, whereas drusen are present as lumps or bumps in the RPE. A bumpy RPE suggestive of drusen. If they are more than 350 microns, they are known as drusenoid pigment epithelial detachments. Now coming to what is a pigment epithelial detachment? It is a separation of the RPE from the Brooks. Normally, the RPE and Brooks are they appear as a single layer. So when there's a gap in between these two, this is known as a pigment epithelial detachment. There are mainly three types: serous, drusenoid, and fibrovascular. So in serous, there's an optically empty space below the RPE. In drusenoid PED, they appear as drusen, and you can see it as a homogeneous reflectivity below the drusen. Whereas in a fibrovascular PED, you will find a heterogeneous reflectivity below the PED. Okay, and this is a CNVM, or a choroidal neovascular membrane, which secretes fluid, intraretinal fluid, also subretinal fluid in the retina. So this is a fibrovascular PED. So then this is a CNVM with intraretinal fluid which has responded to anti-VEGF. This is a CNVM with subretinal fluid which has responded to anti-VEGF. So you can find both of them in age-related macular degeneration. Coming to polypoidal choroidal vasculopathy, so you will find thumb-shaped PEDs here and subretinal fluid. You will also find the double layer sign. That is, you will find a layer of blood vessels between the RPE and the Brooks membrane. So this is called as the double layer sign. It's a very important sign in IPCE. Okay, so coming to VKH, inflammatory pathologies as Vogt-Koyanagi-Harada syndrome. So you will find undulating or a wavy RPE. You will find multiple pockets of subretinal fluid. You will not find intraretinal fluid generally, and you will find septae in the subretinal fluid. So this is very typical of VKH, and you can diagnose it on OCT. And coming to one more important aspect, that is MACTEL. So in MACTEL type 2 or juxtafoveal telangiectasia, I'll be finishing it quickly. We have cavitations or loss of retinal tissue spaces here with the ILM draping over it. This is called as the ILM drape sign. You also have the collapse of the inner retinal layers here. Okay, you can see that there's loss of outer retinal layers, so the inner retinal layers appear to be collapsed downwards. You will also find RPE migration here with back shadowing. So these are the features of MACTEL, and we must learn to pick it up preoperatively. One thing about MACTEL is it is almost bilateral always, though it may be present to different extents in both the eyes. So that gives you a clue if there is MACTEL or not. There are some conditions where you find fluid in the retina, but they do not leak on angiography. This is because mainly the RPE is not functioning and is not pumping out the normal fluid. You will see it in retinitis pigmentosa, macular dystrophies, and X-linked retinoschisis. So this is a patient with cystoid spaces in retinitis pigmentosa. This will not respond to anti-VEGFs or steroids. This is one more patient who was misdiagnosed as a CNVM, an old lady. But actually what happens is she has these yellowish lesions. If you look on the OCT, you find this subretinal white hyperreflective material in both the eyes. And if you do an autofluorescence, you will find hyperautofluorescence. This is actually an adult macular dystrophy or a foveal vitelliform dystrophy. So this is another thing to be kept in the back of your mind. These are rarer diagnoses, but this will help you. It's very easy to pick them up if you have seen them up once. Then this is a case of X-linked retinoschisis, which is seen in younger patients. So you will find a chytic fovea here. So I would like to conclude my talk by saying it's important for us to identify if it's intraretinal or subretinal fluid. It goes a long way in helping coming at the right diagnosis. Thank you.